Dr. Edward Garon discussed the antitumor activity of pembrolizumab and the correlation with programmed death ligand 1 expression in a pooled analysis of patients with advanced non-small cell lung cancer at the ESMO meeting today. Could you explain what data you used to study the efficacy of pembrolizumab in this study population?
Sure. We evaluated 5 separate cohorts as part of the data that I evaluated today. This included one cohort of patients who had not been previously treated for systemic disease, as well as 4 cohorts who had. One of those cohorts was PD-L1 negative patients, while the other 3 cohorts were PD-L1 positive patients. We evaluated patient outcomes with the primary radiographic endpoint of RECIST. Patients were evaluated at different doses and schedules, the highest dose and frequency being 10 milligrams per kilogram every 2 weeks, the lowest dose and schedule being 2 milligrams per kilogram every 3 weeks.
Okay, and what were the characteristics of these patients in your study?
So the characteristics are generally what it would be seen with a standard non-small cell lung cancer clinical trial. The main difference between cohorts was there was one cohort that had not previously received treatment for systemic disease, whereas the other cohorts had, and there was one cohort that was negative for staining of their tumor with PD-L1 antibody, whereas the other cohorts were requiring positivity for that.
And what can you tell us about the overall the ORR in relation with the dose and the schedule?
So, to date, we've seen very little difference in response rate by dose or schedule, at least within the range that I mentioned, between 2 milligrams per kilogram every 3 weeks is the lowest dose we evaluated, and 10 milligrams per kilogram every 2 weeks.
Okay, and what in correlation with the patient characteristics?
So, patient characteristics, the best determination so far in the data set we had was looking at patients who had high levels of expression of PD-L1. That was defined in this group as greater than 50% of the cells having membranous staining for PD-L1. That was the highest predictor. Things that predicted well but not quite as well were any PD-L1 positivity and history of prior or current smoking.
Okay, could you comment on the preliminary PFS data?
Sure. So the PFS and overall survival data that we have looked at are fairly early. This is not an entirely mature data set. However, particularly with correlation with the high staining, if one looks at the patient population who had greater than 50% PD-L1 staining and compares those to people who had less than 50% or no staining for PD-L1, you do see a correlation between this high staining and both progression-free survival and overall survival.
And could you tell us something about ongoing studies with this molecule?
Sure. There are several ongoing studies. The 3 ongoing studies that I addressed in particular were the KEYNOTE-010 study. This is a study in previously treated patients who have received prior platinum-based chemotherapy. They are randomized to either 2 or 10 milligrams per kilogram of pembrolizumab versus docetaxel, and that study is ongoing. There are 2 frontline studies, the KEYNOTE-024 and 042 study. 042 requires PD-L1 positivity like KEYNOTE-010 does, while KEYNOTE-024 requires this high level of staining, the greater than 50% threshold. And those studies are going to randomize patients in the frontline setting to pembrolizumab versus standard platinum-based chemotherapy.